Hello, everyone, and thanks for joining us today. I'm David Gruen, the Chief Medical Officer for Imaging at IBM Watson Health and a diagnostic radiologist at Jefferson Radiology in Connecticut, a RAD Partners affiliate. I'm really happy to be your moderator today for this session on 3D printing. Joining me are Dr. Henry Feldman, Assistant Professor of Medicine at Harvard Medical School and the Deputy Chief Medical Officer for Development with me at IBM Watson Health, and Ryan Hess, the Director of Additive Manufacturing Strategy for our partner, RICO USA. As many of you are aware, medical 3D printing is a really rapidly growing opportunity in technology. By some estimates, it could be a $6 billion market by the year 2027. The opportunities for 3D printing in healthcare are truly vast, from 3D printed implants to personalized surgical planning to enhanced surgical tools. Truthfully, the opportunities are only as broad as our imagination. Today, we'll explore the important and growing role 3D printed anatomical models are specifically playing in education by improving patient and provider experience. We'll examine some of the benefits of educational use cases and learn how IBM and RICO have come together to create a service-based enterprise 3D anatomical model printing workflow to increase provider access to 3D printed anatomical models. As a brief reminder, you're now entering a non-CME portion of the SIIM21 program. It's not eligible for physician CME. So with that as background, thank you all for joining us. Ryan, Henry, thank you very much for your time today. And let's get started. Why don't we start with you, Ryan? Could you describe for us what an end-to-end 3D printing journey might look like, starting from the patient medical image and ending with a completed 3D printed anatomical model?
Yeah, thank you. Absolutely. I think there are some unique aspects to the end-to-end 3D printing workflow that are important to understand before getting started. I'll start with the imaging. The protocols used in patient-specific imaging for the creation of 3D printed models can be different than a typical study. So, for example, RSNA has a 3D printing working group that's given some guidelines around this, where they say that the slice thickness can be optimized based on the intended use, and so the smallest area of interest of the anatomy needs to be captured on multiple sequential images for a particular series. So, one of the common rules of thumb for CT, for example, that we often deal with for 3D printing is that, that slice thickness should be less than 1.25 millimeters. So once you have good DICOM data, there's the need that the industrial additive manufacturing machines that we're using are making models that, that are, you have 20 to 100 micron layers, so less than a half of a millimeter. So when you start with CT data that is, relatively chunky, that slice thickness will produce, stair stepping in the model, even though it may not be as noticeable on the screen. Once the DICOM data has been produced, the regions of interest need to be segmented out. And that typically begins by importing the DICOM images into a dedicated segmentation software. But in the case of iConnect Access, you'd be using the built-in tools. After the region of interest has been segmented out, the data is turned into a surface-based 3D mesh and then converted to a 3D printable file, which is commonly a .stl or .3mf file. Additional CAD work might be needed to be done for the needs of the requesting surgeon. So a biomedical engineer may need to alter the file to create cutouts for fixation points or to insert magnets, if the intention is to use both the external and internal features of the anatomy. There may be also specific 3D printing alterations that need to be done to make the object manufacturable, like thickening thin walls and things like that, or adding color information. So finally, once you have the file ready to be processed, there's a wide variety of additive manufacturing machines available, that can process different materials to create different models that match the clinician's requirements. For example, they may have a need for full color models or models that are flexible and biosimilar, or highly accurate rigid models of bones, for example. So the 3D printers use support materials in order to produce those areas that are not self-supporting. So once the 3D printer is done with its work, you take it out of the build chamber and you have to post-process the model. Post-processing can involve a number of steps, from a solvent bath, manual support removal, UV curing, bead blasting, other methodologies. But many anatomic models have delicate fine details that could be damaged during post-processing. So it's important to take great care when removing support materials. One of the ways that we ensure accuracy of the 3D printed models, that they haven't been 3D printed inaccurately, or that they haven't suffered some sort of a damage during post-processing, is we use 3D scanners to scan the part that was created and compare that with the original manufacturing file. And so the metrology software will help quality control specialists to determine variance over the entire 3D volume and flag errors that fall outside of the manufacturing tolerances. So assuming that the model doesn't have any non-conformities, it can be labeled and then shipped to the customer or the user. And a lot of these labels typically include identification numbers, so you know what the anatomy is, whether or not there was any laterality to it that was being used, which DICOM sets were used to create the model, and so forth. And that's usually included inside the packaging that you receive.
Thanks, Ryan. I'm going to pivot to you, Henry. This is not your mom and pop buy at home 3D printing shop. This is pretty complicated. So Henry, for someone who wants to get started with 3D printing, how do they jump in?
So actually the idea of, build versus buy is almost in every process that we use in either medicine, manufacturing, whatever. And this is one of those perfect examples. And so the first thing that I always do when I sort of make that decision is, what's your expertise on site? And, as Ryan was talking about, they have biomedical engineers in their workflow. And I can't overemphasize the difference between your hacking around with a model versus a engineer who's trained in this. And the printers that you have access to, assuming your budget is not infinite, on your desktop are not going to be the same as what Ricoh will have, for instance, or any other service bureau. Those printers are typically a pretty large fraction of $1 million and, come with a guy. And that guy knows how to use the machine. And even though the costs of those devices keep coming down, when I started 3D printing, an SLS printer, which uses fused powder, would cost $500,000, required special facilities. And for instance, this colon right here, I don't know if it's coming through on the video, was printed on a $20,000 desktop SLS printer, but the post-processing that Ryan was talking about was unbelievably painful. I did that actually as an experiment, and it took me over an hour to post-process that because it comes out in a block of toxic powder, expensive toxic powder, I learned. So often the capital needs of getting a industrialized level of manufacturing is beyond most people's budget. And also, if you just want to find out if it's useful, investing in your own 3D printing infrastructure in-house is an expensive way to go about it, mostly in your own time. As you mentioned, there are home 3D printers, which are remarkably inexpensive. You can get a pretty good one for $500–600. This pelvis right here, the stupid Zoom software is hiding it, but this pelvis was printed on a $700 printer, and it was fine for that purpose. And I think one big difference is also scale, right? If I wanted to produce 50 pelvises a day for, say I'm doing patient education for every patient that's coming into the orthopedics clinic, you're not doing that. Well, I suppose you could, again, depending on the credit limit on your credit card. You're not going to have 50 Prusa i3s in a room printing orthopedic models, whereas, I don't know how big the warehouse is at Ryan's shop, but I'm sure they can produce 50 models in a day if you ask them to. And I think that's the key difference. And also some of those processes that he was talking about, like multicolor, particularly transparent multicolor prints that you see at all the trade shows, which are these gorgeous polished, I don't know how many people really want a liver with all the vessels, but if you do, That is a very expensive object that requires a lot of expertise to produce and a lot of post-processing, and that's just not practical in-house to get started.
I'm just listening to you, Henry, and looking at your pictures and thinking that if it's my colon or my pelvis, I'd much rather have the rigor that Rico brings to the quality assurance that these are anatomically correct than something you might print in your garage. Nothing against your garage, but this is, I think quality matters. And I think that's the advantage of this end-to-end workflow is that, IBM brings iConnect Access, which easily creates 3D rendering kind of in an enterprise viewer experience across different departments, brings silos together into a single viewer from orthopedics to radiology to cardiology to ENT or dental or wherever the need is there. And this zero footprint web-based kind of universal viewer is an easy access for people to get started at the front end. And the partnership with Rico enables this to be completed on the back end in a high quality. So I guess that answers the question, and I'll ask your comments is the advantages of Watson Health and Rico working together on this. Ryan, from your perspective?
Yeah, I think, above all else, at least from my perspective, if we want this technology to make a difference, if we want to, continue to have adoption amongst users, it really has to be easy to engage with. I think that's where we've spent a considerable amount of time exploring the pain points that are associated with the use of these types of tools and what that needs to look like in order to enable adoption. In order to enable adoption as a service model for those healthcare institutions that don't have the budget or the need to enable their own facility. So I think that's one of the primary ways that the collaboration has been able to seek to bring this to more democratized access level. I think from a service model perspective, it can really add value to the provider in that, as Henry was explaining before, they don't need to move into this fully baked. They don't need to have found their 3D printing champions in the different areas. They don't need to have the large budget to set it up and the space and the expertise to run it. The service model aspect may, really provide that access to the anatomic models that give the users that true sense of applicability here. And so, without that direct, integrated, easy, compelling reasons to use it, I think we would see that we'd find a hard time coming out of that 10 to 20% adoption range that we hear the US is in currently with this technology. And so, if they don't have the right resources to segment the DICOM data and prepare the 3D printing files, I think Henry and I have been talking about the role of a biomedical engineer in this process. And, that really can't be underplayed because as the biomedical engineer works with the radiology stakeholders and with the requesters, be it a surgeon or a training organization that wants these type of models, really facilitating that conversation early to understand that you're getting the right quality of input, that you're focusing on the right regions of interest and they're being segmented the right way to be able to manufacture them the way that is needed. That has a direct line of consequence to the quality and accuracy of the physical replica that's produced. So I think that's one of the important factors we've considered in putting this together in the end-to-end that we have, is really ensuring that interoperability and transparency at each step of the process. And so I think it's important that it just has it just works quality of, sort of seamlessly going through that end to end in order to make sure that it's going to be used for the purposes that it can be used for. IBM's iConnect Access provides an excellent example of that integration to both the PACS and the EMR systems that I think kind of exhibits that it just works that we're looking for. Additionally, creating the 3D printing order needs to be easy. And so regardless of how this is done, there are both administrative and clinical functions that are associated with providing this to the healthcare institution. And so, you have to be able to track the sign-offs and sort of the requirements of each of the models that are being made, and understand the costing implications to the hospital or to the institution that's using it. So, the final thing I would say is that, industrial additive manufacturing is still kind of a very arcane knowledge base. In some aspects, it's almost an art form. So allowing a 3D printing service that is dedicated to anatomic modeling to produce and post-process those first models that are being used inside of an institution is really a great time and cost savings. In some ways, maybe the only way to start using these things.
Thanks, Ryan. I'm reflecting that radiologists are pretty comfortable at 3D modeling. It's something we've been doing for quite some time. And so the front end is something that isn't a big leap if you're getting started. And this integrated workflow makes the second half kind of seamless, as you point out. So let's pivot a little bit to some of the specific use cases. Healthcare-focused educational use cases include medical student training, patient engagement through informed consent, and so on. So let's explore how these can improve the lives of patients and medical professions. Let's start with Ryan, you again. Can you share from your experience to how 3D printed anatomical models can positively impact patients and providers when used for educational purposes?
Absolutely, yeah. There's a wide range of uses that we've been considering here, and I think that there's just considerable insight into that's gained by just holding the thing. And so common uses for these types of patient-specific anatomic models that are in the education and communication spaces, being able to work with a patient that is going through a very complex procedure, to show them exactly what approach that is being planned, and allow them to ask questions based on their own anatomy that's being presented to them. And additionally, being able to provide them some additional education around the physiology and the overall anatomy of that's being presented in their particular case. Also, from a clinical standpoint, I think we're gonna have some really great examples coming up of how this can be used for training or for cadaver-free training. I know that there's a lot of medical schools that are looking at simulation centers that are staffed to become cadaver-free or rely on wet labs less than has been in the past. So I think there's a lot of really useful applications here.
Yeah, that's a really great point. Thinking about one of the things we study in medical school are the anatomic variants, and yet a cadaver or a patient only has one of variant. And the ability to use 3D models to accurately predict a unique patient's anatomy has really great advantage for both the surgeon potentially and the patient going into the operation. One of the things I've learned is that 3D printing is not simply rigid plastic like Lego. And I think you're going to share an example of an aortic stenosis model with fragile and crushable calcifications. And maybe you can share that there are multiple polymers with various textures and how this has real impact in training.
Absolutely. I think we actually have a video about that. This is, just pausing on this slide for a second. Well, we can go forward to this. This is a like a use case that comes to us from the Kansai Hospital in Japan, we have a 3D printing group in Japan that is working on anatomic models as well. So this was kind of passed along to me. So to help trainees better understand the relatively common disorder of aortic stenosis, this hospital has constructed a 3D model with crushable calcifications. It's really intended to be a functional replica of the calcification. They used a 71-year-old's pre-operative CT images to make the model. And they sent the data to a multi-material 3D printer. They used both the flexible rubber-like materials as well as a hard engineering plastic to make what you see. And the calcification was made to have a crushable structure by piling up 3/4 millimeter particles triangularly in the manufacturing file in order to accurately simulate those calcifications. And so they performed training for young cardiovascular surgeons in valve resection and decalcification with this model. And it really is designed to simulate a realistic surgical situation by putting the model inside of the aortic root of a pig, so that you can really have an immersive experience. The calcification was crushable by surgical instruments, as well as ultrasonic device. And so really was very similar to doing the actual surgery, and that because of the fragility and the delicate techniques that were needed to be used. So the trainees would not have been able to experience such this kind of training in a conventional wet lab, because pig valves are usually normals, like you had mentioned before.
This is really remarkable. Once again, I know that I'd rather have someone practice here before my chest is open than wonder what they're going to find once they get in there. Henry, you deal with this every day. Thoughts, comments?
Well, so, I think one of the biggest challenges that I've faced when doing a project like what Ryan's describing here is actually figuring out what the educational goal of the thing you're printing. So I had actually an almost identical, it's a different valve. They asked for a mitral valve repair simulator. And the question that came from the cardiovascular surgeons was not, can you build us a mitral valve repair simulator? It was, can you 3D print me a heart? And I was like, sure. But my next question was, is there anybody in the cardiovascular OR who doesn't know what a heart looks like? Because we have way bigger problems if that was true. And so we eventually boiled down to, well, what is it that causes you to, not sleep at night thinking about putting in a Carpentier ring around a mitral valve? And it turns out there's one stitch location that turns out to be potentially lethal when you put it in. And we eventually figured out that actually all they wanted was the atrial ventricular floor with the valve in it, and the valve they actually wanted to work similar to this. And the question was, could we produce just that? And originally we produced a whole outside of the heart, and I discovered the very first thing that the surgical trainees did was they just slashed it in half and opened up the heart. And I was like, which is what they do to your real heart. And it's like, okay, well, that wasn't really part of the educational challenge. So earlier, when you were talking about the fact of being able to collaborate between different departments was key around the imaging, where I looked at a 3D reconstruction of a heart and said, well, show me on here, draw on the model where the parts that you care about from an educational standpoint. And instead of an entire heart, we ended up with a thing that was about 1/4 inch thick. And we actually didn't even print it. We printed a mold. So we took the model, reversed it into a piece of plastic, and then we poured it in silicone, embedding power mesh in it so that it would take a suture, and then laser cutting valves out of silicone soaked power mesh to produce valves that could be sewn. And part of that was working with the surgeon very closely to figure out what is it that they can't do now. Like as shown here, if you had the whole pig heart, you could easily practice putting in the suture, but that turned out to be a problem that it's very hard to see what someone's doing. And actually, if we flip forward a slide, yes, no, Lisa? Yeah, so one of the challenges you often have when you do anatomic modeling or you're trying to assess people's skills is that they don't get a consistent experience. As you pointed out, there are many variants, and most of us who went through anatomy labs suffered with the problem that we opened the cadaver and your patient had that organ removed. Like they don't have a gallbladder. Well, it's pretty hard to learn about the gallbladder when it's not in the patient. And this was one that I got asked by our podiatry department, which was for assessing their residents' skill at repairing a Charcot foot. And the challenge was not, could they find patients with a Charcot foot? It was that every single one of them was a completely different experience. And so the residents didn't feel like they were being assessed on an even playing field. And so the advantage of having a 3D printed model like this is we could produce many of them. And you hand the resident a Sharpie and you say, okay, show me where you're going to cut and where you're going to put together, right? You can use different colored Sharpies to show what you're doing where. And it allowed a standardized assessment across the residents very inexpensively and easily. And, we had the attendings pick their favorite Charcot foot out of all of their patients and 3D printed it. Now, I will tell you, this was a very hard model to post-process because there is no flat surface to print this thing against. And so there were, it took hours of support removal. And if we go to the next slide, Lisa, there we go. So this was another challenge, which was I got asked by our dental faculty if we could make a oral suturing trainer, because not that suturing, inside a mouth is particularly hard, but the problem is when someone's in your mouth, there's no way for someone else to look and see what you're doing. And so traditionally, residents learned on patients. So not cadavers, but like people. And so as you point out, you really don't want to be the first. And so one of the advantages of this, of course, is there are no cheeks in this model. And we worried about things like students were like, oh, we want to be able to fold it up and put it in our bag and bring it to class. And where you see the two missing teeth, we had 3D printed molds that produced silicone inserts that formed the gum pocket that they were going to sew. And this was, with help of a friend who extracted a dental CT for me. And then I built a CAD model where that got embedded in. Now, if we go to the next slide, this was probably the most complex, and this is with my colleague, Seth, who is actually, I see out as an attendee. So I got asked by our interventional radiology team if we could build a biliary PTBD trainer for teaching sort of the C-arm orientation. And I have to say, I had never used a C-arm, obviously, as an internal medicine physician. And so the challenge was, could we make a working model that would allow for working in the IR suite of being able to inject contrast dye? And so what we did was we produced a model, printed it in paraffin, actually on my home printer, and then poured silicone around it, and then fired it in the oven, producing a hollow organ. And so then what we have, the woman in the pink lead there is actually my high school intern for the summer. And in the back is one, now she's faculty, but she was the IR fellow at the time. And the goal was, could this model work so simply that we could have a fellow take essentially a civilian off the street and teach her to perform what is a complex 3D spatial relations based procedure. And in fact, that is my high school student successfully injecting into this artificial gallbladder. And I think, the ability, there probably isn't enough of a market in the world to have a commercial offering for this, but being able to do those kinds of prints. And I will tell you, being able to print in paraffin is a remarkably hard thing. It is a slippery wax that simply does not want to stick to your printer. And so that's the kind of thing where speaking with a biomedical engineer at, a service bureau and saying, hey, I need to produce a meltable model that I want to do lost wax casting in silicone, you're going to get a more professional answer than me trying it in my oven, which is in fact what we did. But this model has stood the test of time, and hundreds of medical students have tried it. And so you can see, you can produce, you don't have to just print the organ, you can print the reverse like this. Modeling, casting, all those kinds of things are in the field of advanced manufacturing. And that's the kind of stuff where having an engineer who can advise you and say, that 3D printing actually isn't the right thing to do here. You want to 3D print a mold because you're going to cast this, or you're going to blow mold it, or whatever it is, vacuum form it, whatever it is, the thing you're going to do might not be the obvious thing to produce the educational output that you want.
So these are incredible examples across a broad swath of medicine. And I think one of the take-home points here is that we've often known that healthcare and medicine are best practiced as a team sport. This is a great example of that, where imaging and surgery and 3D printing expert and those that are doing it and engineering and whoever needs to be can collaborate really seamlessly here to answer this specific question. And with this kind of integrated workflow, we can make it happen pretty easily. Let's pivot a little bit. We've seen some great examples. We've discussed how 3D printing can be used to help providers. I'd like to pivot now to the benefits to patient engagement. So Ryan, why don't you pick up here? How do you see 3D printed anatomical models helping increasing patient engagement experience in terms of consent, understanding procedures, and so on?
Sure. I think the use of anatomic models in patient communication and engagement is really proving to be effective in increasing the patient's knowledge of the affected anatomic area, the understanding of their condition's physiological characteristics, and their understanding of the surgical plan, sort of as we touched on earlier. I think what we've seen is many complex cases center around highly technical surgical approaches, confusing anatomic abnormalities, and these things can be difficult to visualize via DICOM data for anyone, but medically educated native English speakers. And so this can just be simply hard for the patient to understand. Patients that lack that medical understanding, who don't have English as a native or even a second or dominant language, this communication can be less than helpful, intimidating, or just plain unintelligible. So there's a growing body of peer-reviewed studies that were included in the RSNA 3D printing special interest groups work that we touched on before, that's related to the efficacy of anatomic models to the patient communication process and informed consent. After looking at these studies, basically, when a patient-specific anatomic model was used subjectively, patients were shown to rate their satisfaction with pre-surgical consult more positively, as well as their understanding of the planned surgical procedure, and as well as their understanding of their overall condition. More objectively, the studies are saying that this effect was shown to be along the lines of a 50% increase in anatomic understanding, a 40% increase in understanding the overall physiology of the condition, and a 45% increase in the understanding of the planned procedure. And additionally, in regard to patient satisfaction, they rated the use of a model of their own bodies more highly, and often enjoyed keeping the model after the surgery was done. So I think in trying to understand why this is, the way I relate it is that recently Dr. Jonathan Morris of the Mayo Clinic was giving a talk in early May. And he was discussing the growing evidence that these models can improve individual conceptual understanding of complex anatomy, because the brain is good at processing physical objects to give depth and information. So that virtual 3D images that are on a screen are still really two-dimensional for us. Despite being three-dimensional in the computer environment, And so the simulated image is not quite as good as the physical object that's stimulating that depth information that we get. And so, combining the multi-sensory inputs of touch and that real world vision leads to a higher level of spatial conceptualization. So essentially, he referred to this as touch to comprehend, or what others have termed haptic perception. And so I think in general, in looking at these results from the patient's perspective, the patients gain the exact same kind of touch to comprehend perception and understanding that surgeons get from these models. So those results really seem to follow for me.
Henry, what from your experience, how are you using this to engage patients, and how has it been received?
So I'm actually going to slightly switch clinical fields. So I'm also faculty at the Cumming School of Veterinary Medicine at Tufts in our surgical innovation lab. And one of the places we found it to be incredibly useful is when we start talking about implanting a device. And, to you and me, if someone says, well, we're going to replace your hip, we all have an automatic model in our head of what a hip replacement looks like and what that means in the pelvis and what we're going to do to the acetabulum and what we're going to do in the femur. And, if you describe that process to a patient, or in this case, an owner, it's pretty horrific sounding, right? We're going to carve a giant, cone shaped thing out of your pelvis and then chop your femur off and jam a steel rod down your marrow cavity. Sounds pretty horrific until you actually see it and it all sort of makes sense, because part of that is just the words don't mean anything to a civilian. And so, I don't know if you can see this on the Zoom, but this is a 3D printed, for a few dollars, one of the hip implants we use on dogs. And so what we have is we'll have a printout of the dog's pelvis, which doesn't quite look like a human's pelvis, which is another problem that, most people have seen a skeleton, even if it's just at Halloween, and they have an idea what we look like. But when you translate it to a quadruped animal, they just can't understand, because what they think is the knee is really not the knee, and what they think is the ankle is not the ankle, right? I mean, so all the joints are not in the place where you expect it relative to a person. And so explaining where we're going to cut, where we're going to do stuff, it's just not easy for them to visualize. And of course, we can do, like you were saying, show the model on screen. But again, that doesn't resonate with non-medical professionals. I mean, you and I look at a 2D CT slice and we see it in 3D. I mean, I understand when I see a cross section of a kidney, what the kidney that's wrapped around that profile looks like. But to someone who's not used to looking at cross-sectional imaging, it's kind of a mystery, as opposed to, as mine was saying, if I show them a 3D thing in real life and I can demonstrate, here's what the cup that we're going to cut into the acetabular surface is going to look like. And then we're going to take this part of the implant and we're going to glue it in. And then for that matter, we have one that, we just used some, Elmer's glue or whatever and glued it in place. And then, then we put this little cup that's the lubricating surface. And then here's the thing in the femur, and we put it all together right in front of you. And you can see, what the joint's going to look. And that just is a very different explanation than the traditional model of having a photo on the wall or drawing it like we all do. And none of us are artists. And I see someone asked about mixed reality. So using augmented reality or something like that. It's still hard without holding it in your hand, because, sure, I could project it onto something in front of you, but that isn't the same as feeling it, touching it, understanding it. And we've discovered the reality level, like these are obviously made of plastic. I did not make these out of, 316 stainless steel, but I mean, not that we couldn't have, but the expense would be quite high. And there's no reason, because people can make the mental leap from this plastic model represents metal because it's printed silver, versus machining it for real out of stainless steel is a whole different level of complexity. And we found that most of the manufacturers are actually pretty reasonable about sharing their models with us, because they understand we're not going into the business to try and compete against them by making implants to compete. I mean, it's just not a business model that a typical hospital would do. But they understand that, oh, that's a really cool idea to 3D print them, and we're happy to put their name on the display. I think that's something where, and you definitely need help with the radiologist to understand when you're 3D printing it, like, well, how am I going to wrap the femur around, like, where is it going to be in relation to the, the rod in the marrow cavity? Because again, in real life, the surgeon cut it and it's already existing, as opposed to when we're printing it, we have to print it cut. So it really is helpful to have a radiologist who understands what it's going to look like and modify the model for us so that we get it so that it anatomically works right.
Wearing two hats, thinking as a patient once again, if a surgeon could say to me or a provider could say to me, this is actually a model of your particular hip joint, and see this little bone spur, I know it's there, so I know exactly how I'm going to approach it before you're under anesthesia. And I've made sure that the prosthesis that we've selected fits you perfectly before you're under anesthesia. And what this will help us do probably is cut down your operative time a little bit. And there's good data that may reduce your complication rate. And so everything will go more seamlessly because we know what we're going to find unique to you in this patient-centered world based on this 3D model. And from a system perspective, what I'm hearing is this could be a real competitive advantage, right? That if you can give patients confidence that they're in the right place because patients are getting patient-centered care with a 3D model in advance of any kind of a procedure, wow, what a competitive advantage. So again, let's pivot again. What are the current ways that providers can gain access to a 3D printed anatomical model? Ryan, why don't you start here?
Absolutely. Yeah. I mean, to echo what you said about it being competitive advantage, I think, one really good example of that is how Henry Ford Medical Center, uses it to their advantage in their cardiac unit, because, they really have pretty advanced capabilities there. And it makes sense then to try to explain that to your patients, right? We're going to bring all of this technology to bear on your situation because it can really improve everything, from start to finish of that patient's care. So I think what you said is spot on there. To answer the question, what are the current ways that providers can gain access? I think there's a number of ways to go about getting access to anatomic modeling right now. Some institutions are investing in creating their own in-house capabilities, and we've touched on a lot of the requirements for doing that in-house and how there may be some barriers to that. There's also the ability that some surgeons are getting the anatomic model directly from a medical device manufacturer as a part of the use of a medical implant. And so that would be, using the virtual surgical planning tools that are associated with that specific implant, and then getting the surgical models and maybe, other portions of it, like a cutting drilling guide that go along with that implant. And then finally, it's possible to request one-off anatomic models to be fabricated from a number of different companies, selling segmentation software. So there's a variety of ways to go about it. I think with our approach that IBM and RICO are taking, it'll really allow institutions to access the technology using their existing workflows, that are governed by, enterprise accounts that, that have access to those contracted services. The service is really intended to remove specific barriers to entry associated with each one of these ways that you can currently go about getting models today, and in doing so with a SLA-based, easy to use approach.
Henry?
Yeah, so actually, as my suggestion, if you just want to try this out and see how it looks, I actually started anatomic 3D printing by going onto the NIH's 3D Print Exchange. For those who are unfamiliar with it, it's open source, de-identified models that are free, public domain, whatever you want to call it. And I downloaded a bunch of prints and printed them. And, you know, they generally will tell you what the disease state of the patient is. So, you know, if you just want to say, hey, I wonder what a Hill-Sachs fracture of a, you know, in a shoulder looks like, right? I have one actually that I'm sitting over there. And I got asked this week actually by our primary care department, who you don't normally think of wanting procedural simulators, but they're like, we want to have a shoulder injection simulator. And so I went on the NIH print exchange. So instead of having to go find a CT of the good shoulder in our radiology system, I just downloaded a model of a shoulder, and sure, it's got some problem with it, but you know, 5 minutes in Mesh Mixer and I can erase the problem. And then that at least gets me started with a print. And then I can worry about the educational problem of, okay, I need a hollow joint space where, you know, someone can stick a needle and, you know, then obviously we have to put the skin because you want to be able to feel the landmarks through the skin. And so that's a great source for stuff. I mean, obviously your clinic, if you want to produce patient-specific models, you need to start with the patient's imaging. That's not rocket science there. But that, as we talked about very early on, the quality of the model source data is very important. So depending on how your PACS is set up, you may not have easy access to the unvolume reduced images. So one example that my colleague on here, Seth, helped me with, I got asked to produce a radial artery cardiac cath simulator. And so, you know, the cardiologist picked the arm he liked, you know, that was a challenge of some specific type. And, you know, it was usual 1.5 millimeter, 2 millimeter slices on this angiogram. And that was, you know, it looked like Minecraft or Lego bricks. And then, you know, my colleague's like, oh, no, there's the point, whatever it is, 5 millimeter voxel version, the secret version. And I can understand why nobody would ever want to show that to me for real. It was like 1,600 slices for the arm, which, you know, took forever to scroll through. But from a 3D modeling standpoint, it was absolutely gorgeous. Actually, to the point where we started worrying about, like on the patient's skin model, you know, there were her blood vessels and warts and everything were literally preserved. And we were like, you might be able to identify this person's hand if you actually knew who they were. And so we digitally, you know, smoothed out her warts and stuff like that. You know, I guess to use the term, you know, warts and all. But that's the kind of thing where, again, partnerships between departments is incredibly important, where, you know, my ability to get access to the highest quality model and then producing that turned out to be an incredibly hard task, because producing I don't remember what her artery diameter was, but it was like 2.5 millimeter object, the length of your arm with no fractures, was a remarkably hard task. Something that, you know, the kind of technology that I'm sure you guys have, you know, being able to produce that in an SLS printer would have been a much, much easier way to do it than my producing it in tiny little segments and gluing them together, which did ultimately work. But I think that's your real question is, are you producing a generic teaching model, in which case it may not matter what the source is, whether it's from like the print exchange or just a random CT you get access to from a teaching file, or the individual patient. And if you're doing the individual patient, as an informatician, you have to have in your workflow some ability to match the model with the patient, like whether that's embedding the medical record number in the model, in which case you now have to worry about that is PHI. And so making sure that that is a closed loop workflow such that you do not end up with someone else's model in the room when you go to consent to patient, because that looks pretty embarrassing when you suddenly realize that the shoulder you're holding up is not the patient's shoulder in front of you. And so you definitely want to make sure that there is some method of hard matching, and when you get it back to your hospital or your clinic, that you know which patient it matches to. So the workflow doesn't stop after, you know, Ryan's group puts it in a box and sends it back to you, because that is now essentially part of the medical record that you need to preserve and move around in your hospital the way you would any other piece of medical data. And, you know, the PAC system is great at preserving the original source model and the fact that you sent it off to be printed, but there's a physical model that needs to go into a closet somewhere, and that needs to be, if it's part of the consent process, you need to preserve it as anything else you did in the room during that consent. And so that's another thing that a hospital needs to consider before they embark on a 3D printing program, is what to do with, thousands of models that are going to be produced by surgeons all over the place.
It's a great question. I'd like to leave time for question and answer. This has been a really great conversation. Final question for both of you before we open this up to some Q&A. Ryan, you first. What do you see, and we're circling back to kind of where we started, what do you see as the key benefits of an enterprise 3D printing workflow and a 3D printing service versus an in-house operation? And how does this improve collaboration and effectiveness of the clinical team? So really briefly, a final summary of what we've talked about, and then we'll pivot to Henry for the same question.
I guess, I think that the interoperability of it makes a big difference in effectiveness and ease of use. There are so many systems that are involved in allowing this kind of collaboration that, integration is one of the only ways to keep it from being mired in manual effort, or a niche like onesie twosie kind of tool. The enterprise 3D printing workflow needs to connect imaging and surgical through the enablement of administrative functions like scanning protocol selection for radiology requests, ERP functions like APAR. The tools need to be easy to use and natively foster that cross-functional communication for clear insight into complex requirements and project status. It should enable better management of the requisite imaging and subsequent 3D printing information and increase access to the data at each stage.
Ryan, thanks. Henry, last word to you.
And I think, it really depends on what your goals are. So, Ryan had talked about his metrology group, which assures, accurate modeling. And if you're using it for educational purposes, that's obviously less critical that, your hip joint is exactly the size of your hip joint. But in general, that is a significant add-on. And I think, again, I'm going to keep coming back to the fact that he's got a biomedical engineer, and that is not a trivial piece of service to obtain. So I do mostly my own 3D printing, but occasionally I need an engineer who actually knows what they're doing. And, I sort of play engineer, but they're like, you wouldn't go on a bridge that was designed by someone who isn't an actual structural engineer. And there's no like engineer in a box who's just sitting there waiting for a phone call from you. And that's part of the challenge if you don't have a workflow that includes that. And so we've done some 3D printing for medical device trials and research at the hospital. And it's been a challenge when we didn't have easy access to a biomedical engineer. And one of them, we actually ended up hiring an engineer onto the project, which was obviously a significant expense when he didn't sort of come with the printer. Whereas in the model that we're showing here at the Service Bureau, he came with the printer. And when you can involve them at the beginning of the project, it saves enormous amounts of effort later. I mean, there was one project I did with our thoracic surgery department where at the end, when I was like, okay, now we're going to transition from 3D printed prototypes to a manufactured object for the phase 1 clinical trial, I submitted it to the manufacturing engineer who looked at me and he's like, what idiot designed this thing? And I was like, me? Right. And it was partly because I just didn't understand, injection molding and mold making. And, the engineer is like, my God, man, did you not worry about this? And, over 2 hours, he proceeded to teach me all the things I didn't understand about injection molding technology. And that's where, if you tell the engineer, my goal of this is to ultimately get to here, they'll help you. I mean, they have the knowledge and the training to do that. I mean, the same way as if you tell your radiologist what you want out of the image, they can protocol it to get you the thing you want, as opposed to, just give me an image of the head. The radiologist is going to go, okay, well, I'll just do a regular head CT unless you tell me otherwise. And that's where I think the integrated workflow with all of the specialists along the way, and the guy who comes with the printer who understands how to get the right settings on the printer so that the thing comes out the way you want it. I mean, anybody who's 3D printed has certainly printed with the wrong settings and ended up with a nice blob of plastic. So I think that's where the ability to add experts along the pathway without having to purchase those experts yourself is very important, especially early on in your 3D printing journey, and being able to do it at scale. I mean, if you're producing 50 models a day, that's a big engineering department you're going to need at your shop if you want to do it yourself.
Henry and Ryan, thank you very much. So to all of those of you who have joined us, thank you so much for joining our panel discussion today. If you're interested in getting started with 3D printing, please feel free to reach out to any of us through either the SIIM format or separately offline. We look forward to keeping the conversation going. And now we'd love to hear from our audience. Can we please open the floor up for questions?
Right, so I have the Q&A box open, and Alex Tobin asks, yesterday we learned about mixed reality models. How do you think that 3D printing will complement mixed reality? What will 3D printing be used for as compared to the digital models?
I mean, I think, talking about like what Ryan was talking about earlier, handing a patient a thing as opposed, which they can touch and feel and, hold up to their own body. Unless you need to sort of see through your body, I find the physical models in some ways are easier to deal with than, say an augmented reality projection. I mean, part of the difference is, if I want to draw on this pelvis, speaking about alternate reality here, Zoom keeps hiding it, but I can take a Sharpie and I can mark up on this thing, like, here's where I'm going to put a hole. Here's where I'm going to put a hole. You can't do that easily as a normal person. I mean, yes, I edit 3D models all the time, and I probably could figure out how to do it on an AR model, but that's a lot harder than grabbing a Sharpie and just marking on a piece of plastic. And the huge advantage of the Sharpie on the piece of plastic, since I'm going to treat it like part of the medical record, is my markup is actually preserved on that model.
I think, from my perspective, when I look at augmented reality use cases of, taking the thing and then being able to have the laminar blood flow and be able to see it, like in its live scenario, is an interesting concept. Because you do get both of those, pieces of learning. I think, it's tricky from a technical standpoint to actually pull that off well enough that the learning is enabled, is worth, like the juice is worth the squeeze, I guess is what they say. Because then if it's too clunky, then it just simply won't work well enough for you to really get a sense of what you're trying to see in order to change your approach. And then with the VR applications, these things are a lot like Henry was describing. When you get them set up perfectly, they appear in 3 dimensions in thin air, but often manipulating them is less easy in a VR situation than you can just on your screen using your mouse. And also just from having used a lot of the VR situations, I did not realize this, but there's a good portion of the public, including myself, who actually feels kind of queasy after being in VR because the parallax problem, and so I did not realize that was more common than I understood it to be. So for some people, just using the VR is kind of
I deal with enough nausea in my clinical practice. I don't need to make my patients nauseous.
All right,
but also you need to be able to see in
folks.
something. You probably can't see this, but this is actually, we printed in clear resin a virtual colonoscopy. So we tried the fly-through virtual colonoscopy, and patients don't understand because you're zipping through what looks like the Ted Williams tunnel on the way to the airport, except it's your colon. right? And so unless you know what a colon's supposed to look like, you're like, I don't know, I'm flying in a tube that has ripples in the walls. And, there's like a little bump over there and you're like, oh, that's a polyp. And they're like, that's a polyp. That doesn't look like anything. And so, being able to hand someone a physical model often I find just makes it more apparent as to, because it's very hard inside an AR model or a VR model to figure out where you are in relation to, the rest of the body. I mean, we all as physicians can look at a chunk of colon and say, okay, I must be in the transverse colon because the house drawer this way or whatever. But people who aren't medically trained aren't going to know just by looking around at the walls where they are.
Well, team, I think we're at the end of our time. Obviously, we could talk about the opportunities here all day long. Henry, Ryan, folks at SIIM, Nikki, thank you all so much for helping organize this really great session. I hope we've inspired you to start thinking about how 3D printing can really benefit patients and providers in your institution. Please feel free to reach out to us at any point for more information, and we look forward to connecting with you in the future. So thank you all for joining us today.
Thank you. Have a great day.